Hello and welcome back for episode 30 of the Noobie Dentist Podcast. I'm your host, Dr. Omid Azami. It's quite exciting to be releasing the 30th episode of the Noobie Dentist Podcast. I started this just under a year ago as a little hobby, and I thought I would just get a few episodes out and see where it goes. And it's been quite exciting, the journey. The pleasure I've had to chat to so many fantastic dentists from around the world to connect with and learn from, and have the opportunity to build some friendships and have some lasting mentorship from people who I admire. So in this episode, I have Dr. Davey Alleman, who's a fantastic young dentist based in the United States. He is, an advocate and a connoisseur, if you will, of biomimetic dentistry. He grew up around it thanks to his dad, who is Davey Alleman, who is also one of the main, fathers of biomimetic dentistry. Davey Alleman in this episode kind of blew my mind, to be honest. It changed the way I started practicing dentistry pretty much from the day after I recorded this interview. And it kind of opened my eyes and understanding to what it takes to have, proper bonding protocol, long-lasting composite restorations, indirect restorations, all under the umbrella of the biomimetic philosophy of dentistry. I'm a big fan of biomimetics. I think it is modern dentistry. It's something that I think we will be moving towards more and more in the next coming years. And I think it's one of those things that dental students in maybe 10 years will look back on, and the way that we used to, the JV Black classification of extending for retention is going to be quite archaic, to be honest, compared to what we can do with adhesive dentistry, with the chemistry and the biology and everything that's being worked on by so many brilliant people around the planet right now. So this episode with Davey Alleman, I hope you guys enjoy it. I really certainly did. And like I said, it really changed the way I started practicing dentistry and has made a big lasting impact on me. So I hope you guys get a lot of value from this episode. For those of you who are based in Melbourne, Australia, I have partnered up with Dr. Varun Garg and Dr. Bharat Agrawal, and we are releasing the Noobie Dentist Study Club, which I'm quite proud of. It's something that I've wanted to do for a long time, and now that I'm going to be stationed in Melbourne, Australia for the next few years, I thought it was time to kind of partner up with some fantastic young dentists and get something off the ground. So the first event, which is based around aesthetic dentistry, is going to be held on October the 29th in Melbourne. So check out Facebook or message me on Instagram or on Facebook if you have any questions about the detail. Tickets are available and they're selling fast. We have limited the attendance just to 30 people, so try and get on there before we sell out to avoid any disappointment. I hope to meet you guys there. It'll be fantastic to connect and network with some of the listeners of the show. We'll jump right into the episode. I hope you guys have some pen and paper ready, because there's a lot of fantastic tips in here. And Davey Alleman, I'll link his Instagram account, and he sent me some papers, so I'll try and attach those into the show notes as well for you guys for reference. Yeah, enjoy the episode.
Hello, and welcome to the Noobie Dentist Podcast, the safe place for newbie dentists to connect, collaborate, learn, and grow. The Noobie Dentist Podcast aims to provide high-quality and high-value content for all the newbie dentists out there. With your host, Dr. Omid Azami.
Yeah, that's perfect. All right, so if you're ready to go, I usually just like to start off with like a bit of your background, just so we get to know you a little bit, sort of what your journey's been like through dental school. And after that, I kind of want to just really like do a bit of a deep dive into like biomimetic stuff. I know that's your area of expertise, and it'd be cool to just like
buckle up, man.
Talk about a few things like that. So
you came to the right guy.
Yeah, that's perfect.
2009, got accepted to University of Pacific, but there was a dental school opening up in Utah, very close to where I grew up, and we were hoping that they would be more progressive as far as how they approached restorative dentistry, so kind of getting away from GB Black and really embracing some of these biomimetic principles that can really benefit the patient. And so I got wind that they were going to open up the school in 2010.
Okay.
Some insider information from some of it was on the board. So I turned down my acceptance to University of Pacific. They really love nepotism.
Yeah.
It's like if you have a relative that went to UOP, you're in. You're basically going to get.
It's like the legacy and like sororities and frats and stuff.
Yeah, I'm not all about that kind of stuff.
Yeah.
But Anyway.
Yeah.
But it ended up being 2011 that the school actually ended up opening up. So I had a 2-year hiatus. I worked with my dad as a dental assistant and helped him, teach courses to dentists.
Yeah. So you're pretty well prepared going into dental school. You kind of knew pretty much.
Like being well prepared is not necessarily a good thing.
Yeah.
You can know too much and then you've got this huge bullseye on your back.
Oh, yeah.
Dental school soon becomes the longest 4 years of your life.
So you started off in Utah 2012?
2011. So Roseman University of Health Sciences.
Okay.
I was in the first class, and so there's always some good things and some bad things being in
you're the
class.
guinea pigs. They're trying to figure out the curriculum and how things kind of work. So you finished up in, I guess 2015. 15. Okay, so you've been out for about 3 or 4 years now. And like we were talking beforehand, you said you sort of signed up with the military. So is that something that you knew all along you were gonna do? Is that something that you had planned ahead for, or is it kind of just, it came about as you started dental school?
Well, you've experienced it. Dental school can get kind of expensive, right?
Yeah.
And so, my dad, when he went to University of Pacific, it was a lot cheaper then, but he did the Navy route. And so he did a military payback, year for year. And, it was a good situation for him and our family. I wasn't born when he was in dental school, but I kind of knew that was a good way to pay for dental school. So when I got accepted to UOP, I went through the paperwork, decided, let's have the military pay for it. I ended up, withdrawing my application. Before I actually withdrew my application from UOP, they flew me out to San Antonio, and I was a little off put by how much they were spending on me just for a physical. They flew me to, the state of Texas. Yeah. To give me a physical. And I'm just like, dude, I'm an economics major. So the cost benefit analysis was this is outrageous. Why would anybody do that?
Yeah.
So
yeah.
I said the Army wasn't for me then. And then, UOP wasn't for me then. Yeah. And then, 2 years later, I get into Roseman. They accept me and say, oh, it's going to be roughly $400,000 over the 4 years. I'm like, that's a lot of money. So I told my wife.
Slide you out to Texas.
So I just say, well, I'll just go and see what the recruiter says. Yeah. They had all my paperwork from 2 years before. And so I'm like, sweet. If I don't have to do all the paperwork again, let's just throw it in. And if I get this scholarship, we'll play Army.
And are these things competitive? Is there a lot of dental students who apply and don't get it? Or is it pretty much if you want to do it, you pretty much
I think it's a lot more competitive now. I think a lot of
with the tuition going up and everything
are pretty aware of the price tag. That being said, certain branches of the military are more competitive. So the Air Force, they only were giving out 2-year, 3-year scholarships. Yeah. And so I was like, they're not going to pay for all of it. Whatever. The Navy, I almost drowned as a kid when I was 11 years old, 10 years old. Yeah. So being around a body of water wasn't necessarily my idea of how I wanted to die. Yeah. So it only left me with the Army, and the Army was giving away a nice little signing bonus if you got the 4-year scholarship. And
nice.
I had good enough grades and a good enough DAT score that I was competitive, got it. I'm really grateful for it, but there's some days that I'm just
yeah. And so what's the commitment during dental school? How many sort of hours a week or a month you have to commit to being on base or training or all that kind of stuff?
I think it's different for every situation, but for me, the commitment was 0. So
nice.
It's considered inactive ready reserve. And I grew out my hair to, shoulder length.
Nice.
Grew a beard, that kind of stuff. And I knew it was going to all be cut away. I wouldn't be able to live the dream of a beach bum, right?
So. And then, since then, now that you've finished up school, you've been out for, obviously 3 or 4 years. So have you been sort of stationed in one base this whole time, or you've been moving around a little bit? Tell me a little bit about what's been like since you graduated.
So one thing that I would recommend that anybody that's in the military is that if you're not going to do a 1-year AEGD to try and get to a small base or overseas. Because if you can do that, you just have a little bit more, freedom as far as what you're able to provide as the provider. You're not necessarily just pigeonholed into, doing, exams all the time. Like there are some situations where you get stationed at a large military installation and you'll be doing exams for new recruits, 3 or 4 days a week, just 8 hours of exams. And so you're really not doing any, clinical dentistry.
Yeah.
And if you're at some other larger installations that have AEGD programs, you can get some of that work can get
like diverted towards that program.
It gets diverted to the residents, and you kind of get, you're a little lower on the totem pole. Yeah.
So I guess it's similar to like private practice in the sense that if you're working rural, or like in a small base, like you said, there's less dentists around, there's less people around that you got to compete with to kind of get procedures, right? So there's a little more on your shoulders. You can kind of, within your comfort zone, kind of grow a bit quicker that way. I guess that seems to be similar for you as well.
Exactly. And so you kind of do what you really like to do and what you want to get better at. So as long as you have a good mentor, you really could, really do a lot of wisdom teeth and become really proficient at that.
Yeah.
Or, I really like to do operative dentistry. So, and nobody likes to do that. I'm weird.
Yeah. So. Awesome, man. So let's talk about, I was happy to have you on the podcast today because obviously your work with like biomimetic dentistry, restorative dentistry, there's a lot of, Instagram pages and everything like on that topic. And it's an area where I think it's not like implants or like, surgery or even like CEREC and indirect restorations. With direct restorative, like it's something that everyone should be able to do if they put in the time and do it. And it's something that we all do day in, day out, obviously different levels and different success rates and different longevities and everything. But I think it's a very useful topic, biomimetic dentistry, for especially new grads, which like the target of the podcast here is. So if you wanted to maybe just, and obviously like we mentioned before, your dad's sort of, one of the early guys in this whole space. And so you had a really early exposure to it and, running the courses and everything too. You got a lot of repetitions even before you went into dental school. So how do you want to kind of tackle this situation? Do you want to maybe just start off with giving me like the overarching like philosophy of what biomimetic dentistry is, and then we can kind of dive in a little bit more and talk about the certain points and topics a little bit deeper?
Yeah, I would love to. So I think everybody implements biomimetic dentistry in some aspect of their clinical practice.
Okay.
Now, I think eventually the word is going to become a buzzword like, I'm a cosmetic dentist.
Yeah.
But the question that I always ask is, do you still cut teeth down for crowns? And if the answer is yes, then I would say you're not a true biomimetic dentist.
Yeah.
Now that's going to rub some people really wrong. The people, people get really excited about, zirconia crowns or Emax crowns, or I don't think people get as excited about PFM crowns as much, but, but anyway, anytime that you're cutting tooth structure away for retention, you are weakening the tooth, you're weakening the restoration. And as the tooth is in function, it no longer behaves like a virgin tooth. So the whole idea of biomimetic is mimicking life, if that makes sense.
Yeah.
So there's nothing better than the intact tooth. And so if I can restore a tooth and regain its structural integrity through proper adhesive protocols that adequately stress reduce the restoration, then that you can basically stop the dental death cycle. So, imagine if every dentist was really good at doing class 2 restorations. How much endo would you see later on?
Yeah, it'd be reduced by a lot if it's not leaking at the margins, if there's no voids or anything like that. Yeah.
So typically a tooth will go from a small filling to a bigger filling, maybe to a crown, and then endo through the crown, and then a new crown, and then, there was an undiagnosed crack, And the tooth ends up having to be extracted, and then, you're stuck with an implant.
Yeah.
And
so the restorative cycle.
It's a restorative cycle. And if you can stop this early on, you've basically done this huge service for this patient and eliminated 70% of the dental work down the road.
Yeah.
So the question is, how do you do that? How do you keep a tooth properly sealed and properly bonded? I don't think a lot of dentists understand that.
Yeah.
They all think that their bonding system is perfect. Their restorative technique is perfect. And in, 4 to 6 years, they're redoing their work, and it's more aggressive. And, eventually, they get CE training on how to do implants, and they're really excited about placing an implant or doing the endo. Yeah. For me, I've never placed an implant. I've done some endo, but I've prevented a ton of it. Does that make sense?
Yeah.
So if you can prevent it, how much nicer is that than trying to do something heroic later on?
For sure. It's more predictable early on, always, than to kind of like manage the situation as it arises down the line, I think.
Exactly. So with biomimetic dentistry, the whole idea is to do the minimal amount of dentistry necessary for the tooth.
Yeah.
Doing that, we're trying to regain the biomechanics of the tooth and the restoration complex.
Okay. So, all right. So that's great. So let's, if you don't mind, let's start with, I guess we'll start with bonding. That's, where all this pretty much starts, I think. Longevity, the success rates, post-op sensitivity issues. There's so many different bonding systems. There's so many different, I'm someone who's like tries to keep up with these things like through Instagram and, through talking with people like you and like asking questions. But even now, like there's so many, like, do you total etch? Do you selective etch? Like how long do you apply the primer for? How long do you put the bond on for? What bonding material? Do you use 2-bottle system or like, there's so many different variabilities. And that's where I think most dentists, even associates still come into a practice.
And they'll use whatever's in the office.
Yeah, whatever is there. Exactly. Okay. The principal dentist does total etch with like Scotch bond. I'll do that. And then let's see how things go. So let's talk about bonding. It's up to you. How deep and thorough you want to get into it. I'd love it if you can go as thorough as you're comfortable going.
You brought up a really good point. A lot of dentists coming out of dental school, they're only exposed to one bonding system, and that's whatever the manufacturer gave to the school. Now, hopefully your school has a good relationship with a good manufacturer. And I think I've listened to enough of your podcasts that I know that you had SE bond in dental school.
Yeah.
Now, that's way better than what most dental schools in the United States have available to them. And so they come out and they think, Optibond Solo is just as good as Optibond FL.
Yeah.
And I shake my head. Or they'll say, I've got a self-etching primer all in one universal system. It's just as good as SC bond. Yeah. And I'll shake my head and say, no, it's not. But this idea that bonding is simple is completely false. Bonding is difficult. Bonding to enamel is easy. Whenever you have something dry and you're bonding something that's hydrophobic, that's easy. But as soon as you're dealing with a wet surface, it becomes a little bit more challenging. And so before we talk about dentin and enamel bonding, I would like to just talk about dentin and enamel. So with enamel, what's the inorganic percentage? It's like 95%, correct?
Yeah.
Now with dentin, those numbers vary depending if you're talking by weight or by volume. But it's the critical number is it's 50% inorganic. And so you have a big jump of you're bonding to proteins and collagen and that kind of stuff. Whereas with enamel, you're just bonding to, hydroxyapatite. And so if you understand this, then you can understand what I'm looking for in an adhesive. So the big breakthrough was the molecule HEMA, which allowed for, a hybrid layer to form. So everybody with every kind of bonding system has some kind of etching system. So either that you would do a phosphoric acid etch, which would be a total etch system, or you would do a self-etching primer, which is a little less aggressive, but it still denatures the collagen fibrils and the hydroxyapatite crystals that are encapsulating the those bundles, to the point that you can get resin infiltration. So the resin infiltration of this decalcified layer is termed as the hybrid layer. Does that make sense?
Yeah.
If you can keep the seal, that's the most important thing. So, Omid, it seems like you take good care of your hair, right?
Yeah, I try to.
Yeah, you try to. Not me so much, right? But anyway, like people that are really serious about hair care, they'll usually do shampoo and conditioner separate bottles, right?
Yeah.
Maybe they spend $60 on their conditioner. Or if you're lazy like myself, you do an all-in-one, right?
I have there's a 3-in-1 now, like body wash, shampoo, conditioner.
Yeah, that's something that I would totally buy.
Yeah.
But I totally wouldn't use it on a tooth.
Yeah.
So anytime that you can separate chemistries, you're going to have a better result. Because every part of the bonding system can interact differently with the material. So for instance, like if we talk about just a 3-step total etch system. So you etch the dentin less than the enamel, and then you prime the tooth. So the question is, what is the primer doing? So it's a hydrophilic monomer that's able to infiltrate the wet dentin. That makes sense? Yeah. And when I say wet, I'm not saying that it's just spitting out water. Not like that. Even when dentin looks dry, it's much wetter than enamel. That makes sense.
Yeah.
So that primer is got a hydrophilic monomer with a hydrophobic end of that carbon chain.
Yeah.
And so that hydrophilic monomer is really important. So it infiltrates the dentin. And then what you want to do is you always got to get rid of the solvent that's carrying this hydrophilic monomer. Now the most common solvents are ethanol and acetone. If the adhesive has a solvent of acetone, it's going to be much more technique sensitive than an ethanol based primer.
Okay, interesting.
And I think most adhesives have kind of moved more towards an ethanol, but the first bonding systems that were really marketed relied heavily on acetone, and that's when people say, posterior composites are going to be sensitive, posterior composites don't last, that kind of stuff. By using ethanol as the solvent and water, you're able to predictably remove the solvent from that hydrophilic monomer. So
is that because the ethanol sort of evaporates easier if you're just air drying it versus what the acetone used to do, or?
Yes. So with the acetone ones, you'd have to do a lot more layers, and I don't know if that's more because of the volatility of acetone. I'm not a perfect expert on that, but I just know that acetone primers are usually a bad thing in your adhesive.
Yeah. Okay.
I think Prime and Bond NT is one that relied heavily on that was very popular in the US for a number of years. But if you have an ethanol water mixture, the evaporation is much more predictable than just an acetone solvent.
Yeah.
Now, I talked about that little hydrophobic end of that monomer in the primer, right? Yeah. That's just kind of hanging out. That's ready for, when you
grabbing the resin
on there, which is completely hydrophobic, so you can actually have a chemical free radical reaction when a light is placed on it. And so if you have a primer that's very hydrophilic, and then you have an adhesive that's very hydrophobic that loves the dry, why would I ever want to have an adhesive that's combined with those two?
Yeah, it doesn't make sense.
Think about it. It's like all of us have seen a vinaigrette and where it's separated, where the oil and the water is separated. That's a perfect illustration. So, even if you've got this perfectly mixed hydrophilic, hydrophobic vinaigrette bonding system, you still have the problem that you have to get the solvent out. And so now you're blowing all this air into your adhesive, trying to, remove the solvent. And if I could, stress it enough, the more you can separate the chemistries, the better your bonding will be.
Yeah, I think that's a good principle. Makes sense.
So
it's tried and true. It's been done for a long time. We've seen good results.
So the best 3-step total etch system on the market is still Optibond FL.
Yeah.
And the FL stands for filled. It's not necessarily it's not for fluoride. It's a filled adhesive, and it creates a thicker interface. And now this is the same thing with self-etching systems. So if you're going with a self-etching system, the acid is mixed with the primer.
Yeah.
And that's not going to have a negative impact. It will denature the collagen enough that decalcify the dentin enough that you can get a very predictable hybrid layer and very high bond strength. But the same principle applies. You want to remove the solvent in that primer. And so when you're using a self-etch system like SC Bond or SC Protect, those are the two that I would recommend as the gold standard, which has been proven in the literature to, be the best as far as consistent bond strengths throughout the tooth. And so you air dry the water ethanol solvent in that primer, and now you're allowed to proceed to create a uniform hybrid layer and a predictable bond to the tooth. Now, with the total etch system, you're relying only on micromechanical retention. With the mild self-etch system like SC Bond or SC Protect, there's been some studies out of Japan where they actually showed an ionic bond form with the calcium ions in the tooth.
Nice. So I was going to ask you, that's a good segue quickly, just to branch out for a second. In Australia, especially since I've moved back, and even in school, like they use a lot of glass ionomers here, more so than like for sure in Canada. Like Canada, where I was working, not many offices had Fuji 2, Fuji 9, Fuji 7, like different glass ionomers, like resin modified glass ionomers. What's the downside of here that even in school we're taught, you can use like a glass ionomer as like a base to like replace dentin and an enamel on top. And the benefit of the glass ionomer being that you can like have ionic bonds with the dentin, so it's like a really good bond strength. What's your thought about that? Maybe instead of bonding directly to composite to dentin, to do like a intermediately layer with like a glass ionomer or like a Theracal or even or something like a liner bit material.
So that's a really good question. I think a lot of people miss the boat on this, and we have to know what an ideal or a biomimetic bond is. Mm-hmm. So there was an important published in 2004 where Urabi actually did a microtensile bond test of the enamel and the dentin. So he wanted to find out what the bond strength of the DEJ was.
Yeah.
And he pulled it apart, and he found that number to be right around 51, 52. So low 50s, high 40s.
Yeah.
So if I can get a bond system to 40 to 50 plus megapascals, then I know I have a biomimetic bond. It's lifelike. It's mimicking the DEJ, which is nature's bond.
Yeah.
So with Optibond FL, you will get a bond strength of 50 plus in a low C factor situation.
Nice.
With SE Bond, it depends on how you prepare the dentin. If you use air abrasion before you bond the tooth, you will get bonds of 50 plus. If you use a diamond, it'll be closer to lower 40s. And that has to do with the thickness of the smear layer that is compacted with air abrasion. So that's what I'm always shooting for. That's the goal. The goal is to always have a bond strength of 40 to 50 megapascals.
Yeah, because anything beyond that's not natural. So
exactly.
You're doing a man-made thing that's not mimicking what naturally would have occurred. It's a good point. I like it.
Well, let's go to like what is glass ionomer bond at, or as a modified glass ionomer?
Yeah.
A lot of people use Vitribond. Well, Vitribond on sound dentin will bond at about 12 megapascals.
Wow. Okay.
Now, with glass ionomers and resin modified glass ionomers, it's such a brittle material and such a weak material. The material will actually, as it hardens, will actually crack and break. So you'll actually have, glass ionomer still kind of, bonded to the tooth, whereas the rest of the glass ionomer is kind of separated from itself.
Yeah.
So in my mind, glass ionomers are unnecessary. Resin modified glass ionomers are kind of the worst of both worlds because it has the shrinkage of resin and it doesn't have the fluoride release of glass ionomer. But if I'm trying to mimic the natural tooth, I would never put glass ionomer as a base or a liner because it just doesn't bond as well as a gold standard adhesive like Optibond FL or SC Bond or SC Protect. Now we're going to go deep, man.
Let's do it.
All right. So, I can talk days for this stuff.
All right. So you've
So what do we establish as the biomimetic bond?
Yeah. So it's going to be 50, high 40s to low 50s megapascal. That's what you wanted the DJ. So that's what you want your composite dentin union.
That's what I want my restoration to bond at. I want that to bond at 50 megapascals.
Yeah, and that's as good as nature. So you'd be happy.
That's as good as nature.
Yeah.
So now the question is, how do I keep 50?
Yeah.
Because it's nice to have something be perfectly ideal. How often in practice is a prep ideal?
Depends who's doing it. So, for me, maybe half the time, I'll be happy with that.
If it's half the time, you're doing way better than most. I would say that 0% of it is super ideal.
Okay, I guess it depends on your definition of ideal as well. But
so the next question is, how are we bonding to decay?
Yeah,
because that's what we're really doing as a dentist, right? We're treating decay, and in certain instances, I don't want to remove all the decay. You've seen enough of my Instagram accounts that show.
Yeah,
hey,
you don't want, not at the expense of exposing.
I'm leaving a ton.
Yeah.
So the question is, if I'm leaving affected dentin or infected dentin, how much is that compromising that 50, that bond of 50 megapascals, right?
Yeah.
So, I'm doing a class 2. It's deep. I'm always using Caries detecting dye.
Yeah.
Now, it's a big pet peeve of mine when people downplay the importance of it, because the only way to really know what your bondable structure is through Caries detecting dye. Mm-hmm. The team of researchers out of Tokyo Medical Dental spent a lot of time figuring out how sound dentin bonds to SC bond, how SC bond bonds to affected dentin, how SC bonds to infected dentin.
Yeah.
So now I'm no longer going to use those words of infected and affected, because the inventor of Caries detecting dye is Takao Fujiyama. And Takao Fujiyama invented Caries detecting dye. He was also the first person to actually bond a dentin.
Yeah.
So he's important.
Yeah.
But he had a dental student ask him, he's like, "Oh, I'm really check my prep." And Dr. Fujiyama said, "Well, go until it's hard." We've all heard that, right?
Yeah.
Now, the student was very smart. He said something along the lines of, "Fujiyama sensei, how hard is hard?"
Yeah.
How many of us have felt that way?
Yeah.
Now, if there was a technology that could show you exactly where is hard, where is kind of hard, and where is super soft, I think that would be super valuable for a beginning dentist, right?
For sure.
I think it's super valuable for a very experienced clinician. I see a lot of cases and I'm like, if I put Caries detecting dye, I know that I would have decay in a very important area of the tooth that I want to keep that 40 to 50 megapascal range.
Yeah.
And it, in their mind, it's like, oh, it's hard. I scraped around. Mm-hmm. I took my slow speed and it wasn't cutting very much.
Yeah.
I mean, there's a lot of times where I'm, putting the, my Caries indicator. I'm like, oh, I think I've got it all.
Yeah.
And it's like, I'm glad I put that last coat on. So Fujiyama said, there's different areas of the tooth, and, sound superficial dentin is very easy. It doesn't stain. Now, when it gets light pink, or if you're using a green one, light green, or if you're using a blue one, light blue,
yeah,
this is termed inner caries. And the reason why I'm using inner caries instead of affected dentin is because this is what the published literature refers it.
The terminology is changing a little bit, maybe.
And so inner caries will bond at, about 30 to 50% less of what sound dentin will bond to.
Yeah.
So what's 30% less of 50? About 35, right? That's still like a pretty high number. It's still higher than glass ionomer's 12 on its best day, right?
Yeah.
But there'll be instances where I do not want to expose the nerve. If I expose the nerve, the chances of a root canal increase 3 times.
Yeah.
So I will leave outer caries. Now, outer caries is the same as infected dentin. So it's, the collagen framework has been completely demineralized and denatured to the point where, if it does kind of rebound a little bit, it'll never regain its intact structure like inner caries will.
Yeah.
Where inner caries just has the hydroxyapatite kind of decalcified off of the collagen framework, but the collagen framework is still intact. And if you can get that tooth resealed, then you'll have remineralization there. So does that make sense?
Yeah.
So we know sound tooth structure bonds at 50 on a good day, and then inner caries bonds at 30% less. So that's like 35. Now I've shown cases where I'm bonding to outer caries, where it's very soft. You could take an Explorer or a spoon, and it would be very easy to just expose a nerve.
Yeah.
If I'm going to try to remove all decay. And this will bond, anywhere between 60 and 70% of, my initial bond strength.
Okay.
So we're going to do a little bit of arithmetic. So on outer caries, what will be the bond strength if I, have, 70% bond reduction?
So you're looking at maybe like 15 range?
Yeah, right around 15.
Yeah.
So even if I'm bonding to the worst substrate, it's about as good as glass ionomer on its best day, right?
Nice.
So I think we can assume that, glass ionomer liners, resin modified glass ionomers are unnecessary if you can keep that seal.
Yeah.
Right? So we've just talked about this hierarchy of bondability. Now, all of these bond strengths are on flat surfaces. Now, in your dental school, did they ever talk about C factor?
Yeah.
Okay. What's the definition of C factor?
It's like number of sides bonded.
Yeah. So the ratio of bonded to unbonded surfaces, right?
Yeah.
So a class 1, it has a higher C factor than a class 4, which is, basically flat.
Yeah.
So the question is, when all these people, all these researchers are doing all these awesome experiments to know what the bond strength is to sound dentin and to carious dentin and to in between carious and sound dentin, what surfaces are they bonding to? Flat surface.
Yeah.
So why is that? So if you have a low C factor, the bond can only go one way, right? And so if the bond can go only one way as it shrinks, you are going to have no competing elements to the
interesting, yeah.
To that. So if you're thinking, oh, bulk fill is super awesome. All right. I've talked to this representative. They talked to me about SureFill. They talked to me about, what are some other ones?
SDR.
Sonic Fill, SDR.
Yeah.
And it's gonna make class 2s be done in 15 minutes.
Yeah.
So what does a bulk fill strategy do to your bond strength if we're just talking about sound tooth structure? So we're talking about 50 again.
Yeah.
Well, guess what? Some people in Japan actually studied this. They actually, did high C factor preps, and then they did microtensile bond tests in that area.
Yeah.
What did they find? In a high C factor situation, you lost 50% of your bond strength.
In how long?
24 hours.
Wow.
And then what did they do after that?
So you drop from like a 50 megapascal down to like 25 in 24 hours.
Yeah, and that's talking about being on sound dentin, and it's like, sweet, everything is perfect. This is going to bond so well. Yeah. I'm using my OptiBond FL. I'm using my SC bond. I'm doing everything right.
Yeah.
And then you squirt in that SureFill. What did you do in that 5 minutes? You cut the longevity of the restoration in half.
Wow. So is this because of shrinkage? So you're pulling at the bond from like all angles, and that's what's
exactly. So there's a competition of, what way does the restorative material want to shrink to?
Yeah.
Now the literature says it wants to shrink towards the best bond.
Interesting. Yeah.
And I would also say it wants to shrink towards the quickest forming bond. Now I want you to think about, if you're bonding to something that's totally dry and something that's partially dry, what's going to bond the fastest? If you're putting a sticker on like a wet wall or a dry wall.
The drywall, yeah.
The drywall. So, early on people were like, composites shrink towards the light. Now, a researcher named of Anthony versus Lewis did some studies that prove that wrong. It actually wants to go to the best bond. But where's typically the best bond in a class 1 prep?
The margins?
Or the quickest bond, I should say. Like where's the driest surface?
The enamel ring.
The enamel ring.
Yeah.
And so everyone gets this idea, enamel bonds are very stable. Dentin bonds are actually less stable. It turns out it's, not true. If you can allow a dentin bond to mature without competing,
like with forces onto it,
substrates, the dentin bond will actually bond much higher than enamel, because enamel tension, the tension of enamel is only right around 33 megapascals as far as its cohesive strength within enamel.
Yeah.
Because the enamel rods are brittle and eventually will just.
So let me like dumb this down a little bit.
I told you we were going deep.
Yeah. So it made like I'm enjoying it. So I just want to make sure it's like applicable and useful for people, and just so you can kind of understand it a little bit better. What you're just saying with let the bond mature, that's something that I want to get into with you in a second, but it just made me think of those like 3M adhesive like wall hooks and stuff they put, and they always write down like let it sit for an hour before you load it, like hang a towel on it or a picture frame or whatever. I guess it's the same principle. Like you've bonded it now to the wall to itself. You want to let that bond mature before you're putting competing forces onto it to take away from that. All right, so let's bring it back to the dental thing now. So you've isolated, you've removed your caries, you've used your caries detector dye, you're leaving a bit of dentin that's carious because you don't want to expose pulp. You've done your primer, you've done your bond, you've cured your bond. Is this the point now you're saying let it sit, or are you putting a bit of flowable composite first? Like, talk to me about that next step now.
Exactly. So if you decided to seal the tooth and walk away for 2 weeks and then go back to it, you've actually increased the bond strength to your cavity prep.
Yeah.
Now, people will talk about immediate dentin sealing. That's immediate dentin sealing.
Yeah.
If you're doing a direct restoration, everybody does immediate dentin sealing because, that's what they do. Now, why does immediate dentin sealing work so well on indirect restorations? It allows that bond to mature unimpeded. Does that make sense?
Yeah. Because you're not bonding on top of it. You're just kind of sitting a temp crown or something.
Exactly. So when a material hardens, when you shine the light on something, it takes time for the composite to go through all of its reaction.
Yeah.
So, early on, it jumps up super high to, 70% of the polymerization shrinkage is dissipated, right when the light has been shined on it. Now, at a minute, you get another 10% to about like 80% of the polymerization shrinkage has been dissipated. Now, at 5 minutes, you get about 90%.
Yeah.
30 minutes, 95%, 24 hours, you're basically at 100% of the polymerization shrinkage eliminated. So the question is, if you have these competing entities of dryness of the tooth structure. So the closer you get to the occlusal surface, the drier it gets, the faster that bond forms. The question is how much can I layer before I start negatively impacting the restoration?
Yeah.
Now, one thing that people will do, they'll be like, oh, I'm going to layer my restoration. Now, how they layer the restoration is very important on how it's actually going to impact the bond strength of the tooth. Now, if you do bulk fill, we can all agree that that's bad. You lose 50% of your bond strength right off the bat. A year of occlusion and function, you lose another 10%, so that's 60%. That's a bad technique. So let's do what the manufacturer says. And what does the manufacturer usually say?
Like 2 millimeter increments.
2 millimeters.
Yeah.
So I got a class 2. It's 4 millimeters deep. I'm going to go 2 millimeter, done. I'm going to be done in 30 minutes. I'm going to go sit. For me, it's a Mountain Dew. If you're not a Mormon, it's probably a coffee or whatever. And pat myself on the back for doing a good job.
Yeah.
I layered. Well, guess what? People have actually studied what the bond strength is if you do 2 millimeters. And guess what? The bond strength is similar to a bulk fill technique.
Wow. Yeah.
Just slightly better. And so the question is, why is that? Now, the researcher that showed this is Nikolenko, and this was a very important paper. It's super cool. But he did a bunch of layering techniques. So he did, 4 1 millimeter layering techniques. He did 2 millimeter layering techniques. He did oblique. He did vertical. And he tested the bond strengths on all these. And the one that he found that was the best, after what I've just told you, can you maybe guess?
Probably the oblique.
Now, I think a lot of people would say, yeah, the oblique. That'd be awesome.
It was a vertical. There's less C factor.
That's true to a sense. So if you're going oblique, maybe you're only bonding to 2 walls in a sense. Now, I want you to think about what the C factor is if you're going a very thin layer, a horizontal thin layer of the ratio of bonded to unbonded. So on a class 2. So you're doing a very, very thin layer.
So I guess it only counts as, realistically it's going to be like 1, 2, 3, 4, but realistically it's just 1, which is the floor of the prep.
Exactly. So the surface area is still low. It's still a low C factor increment.
Yeah.
Whereas an oblique could still be a low C factor, in theory. But what is it connecting? It's connecting deep bonds to higher bonds. Does that make sense?
Oh, yeah.
And if I want to protect those deeper areas with the preparation, I don't want to have it touching any of the
higher spots.
Yeah. And so when my dad started teaching this, he, maybe he invented the term. I don't know. But he called it decoupling with time because bonds take time to form. And if I can decouple my bonds deep in the prep from the bonds that are closer to the occlusal surface, then I have a much higher likelihood of keeping the tooth sealed. And so the 4 horizontal increments double the bond strength compared to a bulk fill or
so if you have a 4 millimeter box, like you said, if you do 4 1 millimeter increments, that'll give you the most ideal
exactly
longevity.
What was even more important is he also compared those bonds to the 4 increments of oblique and the 4 increments of vertical. And guess what? It still beat those because it decouples slower maturing bonds from quick forming bonds.
Okay. So let's do this practically. So you've cut a class 2, you've got your rubber dam, everything's good. You've primed it, you've evaporated the solvent, you've put your bond on, cured that. What's your protocol after that? Now you've got the hybrid layer there. Do you put a little bit of flowable to line it first? Do you go straight to composite and do your 1 millimeter increment now? Talk to me about that next step after you've done your bonding.
So everything I do, I want to have a piece of literature tied to my technique.
Yeah.
Now it's really important that you feel that comfortable that you can actually cite, the paper that this is the reason why I'm doing something.
Yeah.
And so what I do next is I resin coat the dentin. And the researcher that showed that was Jaya Surya.
Okay.
And she had to learn Japanese to get her PhD. She's from India.
No way.
But anyway,
Nice.
she showed that if you resin coat the dentin over your adhesive, so a thin layer of flowable, less than 1 millimeter, and then bond an indirect restoration on top of that, that when you pulled it apart, the failure mode would happen at the flowable and the indirect restoration. So basically, the dentin is perfectly sealed still. You failed,
Yeah.
but the dentin is sealed. And so is that really a critical failure? No. So this is something good that we would shoot for. This is what we call a secure bond.
Yeah.
When my dad gave me this paper in the basement, and this was before I was in dental school, I was still in undergrad. He's like, read this. I'm like, okay, cool. So I read it, and I tried to, paraphrase what it was, and he totally got me. I totally missed the boat. But now I don't make that mistake.
Yeah.
So if you resin coat with a microhybrid flowable, you will create a little weakening of the bond of your restoration from the flowable and create a secure bond. I think that's advantageous.
So when you So since you know the numbers, so you said the ideal bond from your hybrid layer to composite is about 50, which is mimicking the DJ. What's the bond strength of the flowable liner that you've put on now and the composite you put on top of it?
So that's a good question. So in this paper, what they did is they took a bunch of teeth, they did some direct restoration, and they pulled them apart, and they failed at about 45 megapascals. Sweet, that's what we want.
That's not bad. Yes,
so now what they did is they did immediate end sealing, and then they resin coated the prep, and then they cemented their onlay with Panavia, and they were pulling apart, and the numbers were right around 27, but the failure was never at the tooth to bond junction. So the question is, what was the tooth bonded at? Is it 27?
Interesting.
Where it failed? Or is it bonded probably at the 45, which the directs were having, but the failure mode kept the dentin completely sealed? Does that make sense?
Yeah, that's good.
So that's a secure bond strategy. And nobody teaches this.
So do you think, if to make it practical again, so if you've done this immediate dentin sealing, you've done the flowable layer to get that base. If there is leakage in your class 2, is it happening between the junction of your composite on top of the flowable? Does that make sense? Like, is that where you would see recurrent decay? I mean, recurrent leakage, or is it just gone altogether because the bacteria doesn't have access to the dentin itself?
Exactly. So when people say, "Oh, I don't want to layer my fillings, so I'm going to do, I'm going to use my SDR bulk fill because I don't want voids and I don't want gaps. I want to do, a big thing that people are talking about is injection molding technique.
Yeah.
Because they don't want any voids or gaps in their class 2.
Yeah.
And can you get decay between 2 layers of composite?
No.
Or between ceramic and composite? No, right? So is that even a really important thing to focus on?
No, that's not.
I would say no. The only thing that I'm worried about is keeping my dentin sealed. If I can keep my dentin sealed, then I don't have recurrent decay. I don't have to go back and redo my work in, 4 to 6 years and, create more dentistry. If I can stop it initially, then that's the best thing.
That's great.
So if I'm resin coating and then I'm continuing to fill with a direct, the bond strength should still be right around 45. But if there were a failure to happen, I would want it to happen at my flowable layer. Does that make sense?
Yeah.
I want a high away.
Okay. So I want to get into a couple of
I got one.
Yeah, go for
one
it.
more caveat on that.
Sure.
So I'm sorry.
That's all right.
But if you're using Optibond FL, the thickness of the adhesive is about 80 microns, whereas SE Protect, SE Bond is 40 microns. And so it's more important to resin coat if you're using SE Bond rather than Optibond FL. Optibond FL also showed that secure bond strategy where it failed, the adhesive thickness acted kind of like that flowable layer.
Okay, interesting.
So that's something you wouldn't have to do.
With,
when I used Optibond FL in Korea, I did that. You know, I still resin coated.
Yeah.
All right, continue on.
All right.
Sorry.
So what I want to ask is, obviously we talked about it already, but I just want to make sure we nail down for people and for myself, like what it entails. So when you talk about immediate dentin sealing, does that include just prime and bond cured, or does it include the resin flowable 1 millimeter layer as well?
So if you're using Optibond FL,
yeah,
it's just, you know, it can be as simple as just the adhesive.
Okay.
If you're using SE bond, I would say that you would want to resin coat because the thickness of the adhesive could be subjected to some oxygen inhibition. So it would be better to still resin coat before you took your impression or scanned your scan for a CEREC, that kind of stuff.
So the next question I have then is, you talked about the maturing of the bond and how at 5 minutes is pretty much 90%. So is that something that you'd be pretty happy with? So say you've done your immediate dentin sealing for a class 2, you've done your bonding, you've put your resin coat. If you wait 5 minutes.
So immediate dentin sealing should only be referred to when you're
indirect,
doing semi-direct or indirect restoration.
Yeah.
If we're talking just about a class 2,
okay, it's just bonding.
This is your bond.
Okay. So you've done your bond. Is it worthwhile then to wait at least 5 minutes for the bond to mature a little bit before layering your composite? Has that been shown at all to be useful or beneficial?
So I'll ask you that same question. Do you think that would be useful?
I think so. Now that you've mentioned the numbers, like if you're waiting 5 minutes and you get 90%, like maybe 24 hours is a bit ridiculous, like in feasibility terms, like bring the patient back, whatever. But 5 minutes to get 90% strength, I think you can manage that probably.
Yeah. So like, let's talk about practicality. Let's say, you're running behind. We're both relatively new clinicians. I'm super slow. You're probably slow. So anyways, we get behind.
Yeah.
And, we're doing a really deep class 2 restoration. The tooth is borderline, maybe needing endo. And so you clean out the decay. You maybe leave a little bit near the nerve. That'll bond less than, where it's clean. And, oh man, I could hurry and finish this up in 5 minutes. I've just put down my adhesive, I'll just get the person out of the door. My next patient's already here. Or I could put my adhesive, maybe put a little bit of flow. And then I'm just going to put, some pink triage there. And I'm going to have the patient come back, in 2 days.
Yeah.
What do you think will happen to the bond? What's the best thing for the patient, actually?
To come back in 2 days. If you're not going to be waiting at least 5 minutes, yeah.
And so Didier Dici did a beautiful study on this where he talked about delayed composite placement. So he was actually doing, class 2s, and he was waiting a day before he was finishing it, and then he'd pull them apart. And what did he find in those? Those teeth that he waited the day had less micro leakage than those that he did it, layered that day.
Yeah.
And so by allowing the bond to mature, you have less defects. Now, how many dentists would do that? I've done it a couple of times. I know my dad's done it. But I don't think a lot of people do that.
Definitely.
But I think it's something that you could use, on a routine basis, and you can charge them whatever you want to charge them, for that initial visit, and then charge them for the final restoration, whether you do it indirect or if you just build it up direct. But the science shows that is beneficial to the bond strength of the tooth. So I think,
I'm just my brain's kind of just like racing here. I'm just thinking of different things. So I think that's another potential cited benefit that you can tell your patient about, like doing indirect, because you're going to seal it, you're going to send the impression off to the lab, or even if you're going to mill it in house with CEREC, by the time that's done, like you've scanned it, you've milled it, stained it, blah, blah, blah. Like the bond's maturing all this time. So 30, 40 minutes. So it's a much better bond strength than you would have had with just a direct filling. Unless you're going to wait anyways.
Absolutely.
That's awesome.
And so, there's been some nice studies that show, have you ever heard of post-gel shrinkage?
Post-gel shrinkage? No.
No. So this is a new thing. So
Yeah.
we've talked about how, your adhesive takes, 24 hours to fully mature.
Yeah.
Right. Well, what is composite? It's basically the same chemistry as your adhesive in rough terms, right? You're using free radical react to make something hard, and it typically shrinks anywhere between 1.5 and 4.5%, depending on the composite you're using. And so the question is, will your resins suffer from the same polymerization curves as your adhesive?
Interesting.
So what would you assume?
I'd say yes.
They do, exactly.
Yeah.
And if you have a highly bonded restoration, you've done really good layering protocols and you kept your bond, where does that stress get transmitted to?
Is it the junction that composite meets the tooth, or?
Yeah, so it gets transferred to the tooth.
Yeah.
So if you're doing bulk fill, when the polymerization shrinkage happens, instantaneously, what ends up happening is, it tries to relieve that, that stress, and it usually delaminates a portion of the prep, which isn't good.
Yeah.
But if you have a perfectly bonded restoration and you use a direct technique, what ends up happening is the bond is so good, it actually will start to strain the residual tooth structure.
Oh, okay.
Does that make sense?
Yeah.
For that 24 hours, that reaction's still kind of going. And so if you want the most stress relieved restoration, an indirect restoration will be the best. Now, there are ways with stress reduced direct protocols and fiber placements that allow you to mitigate some of those stresses and slow down that reaction through pulse and progressive cures. But that's something that, when you're a fully trained biomimetic dentist, you're thinking about the benefit of it. Yeah. It's like, do I want to do this direct, or do I want to do it indirect, or do I want to do it semi-direct chair side?
Yeah.
But the whole idea is, I want the tooth to stay bonded. If the stress gets transferred to the tooth structure, maybe you get a small crack line into enamel because there isn't enough dentin to give it some flexibility and some toughness. Does that make sense?
So you're pulling so say if like in a class 2 again, you pull, or a large MOD, you're putting in the buccal and lingual cusp, we're kind of straining in a little bit. So you're putting flexure.
Yeah, so if you have like a very, very thin buccal and lingual enamel shell.
Yeah.
And it's like, I want to keep as much tooth structure as possible. What would be the best way to not have stress be transmitted over to the through the tooth? It would probably be an indirect or a semi-direct restoration.
Yeah.
Now, if you wanted to do some intricate layering strategies, you could still do that, but you might see some fatiguing of the enamel.
Yeah.
On these really extreme cases. Extreme cases, I would probably say, onlay that cut.
Yeah.
Save yourself the hassle. You'll lower the C factor, blah, blah, blah. But these are the things that are constantly churning in my head. It's like, what's my bond? What's my initial bond?
Yeah.
What am I fighting? Am I fighting inner or outer caries that are going to weaken my bond strength? Am I fighting C factor stresses that can negatively impact my bond strength? Am I fighting residual tooth structure that I still have left that, may be adversely affected?
Yeah. So to avoid a lot of this, indirect would solve a lot of it, right? Because the restorative material itself is not going to be shrinking. So it's going to be a stable thing that you put in at the time of bonding.
If you've seen a couple of my cases where I did a semi-direct composite.
Yeah. I want to talk to you about that too. We'll get into that. Like
they're super cool. They're super fun.
Yeah.
But anyway, if I'm doing all of the polymerization outside of the mouth before I cement my onlay, that material is going through its polymerization reaction separate from the polymerization reaction of my immediate dentin sealing and resin coating, correct?
Yeah.
And so that's going to have less negative outcome as far as residual stress or post-gel shrinkage.
Yeah.
Now, if you're doing Emax, ceramic doesn't shrink.
Yeah.
After you shine the light on it. And when you fire it, it probably does a little bit.
Yeah.
But that's beyond the point.
Yeah.
But you're only dealing with the shrinkage of your cement at that point.
Yeah.
And so an indirect restoration will always be the most stress-reduced restoration possible.
Okay, so let's there's a couple other sort of like buzzwords in biomimetics that you see on Instagram a lot, or definitely on your page and other biomimetic pages as well. And I kind of wanted to touch on those before we sort of move on. And I think they're kind of related. And maybe we've already touched upon some of them, is biobase and like deep margin elevation.
Okay, so biobase is a totally made up word. It comes from my dad. It kind of evolved from my dad's teaching program.
Yeah.
One of his partners, Wendell Robertson, came up with some terms such as, the biobase or the biorim. So the biorim, we'll start with the biorim, sorry.
Yeah.
So biorim is 2 millimeters of enamel above the CEJ. This is where all of the forces of occlusion are being transferred to.
Yeah.
So I can't remember who first said biorim, if it was Wendell or my dad. But eventually, that's basically your prep right before you're ready to bond. And so if you have a biorim, as the tooth is under function, it's going to be able to withstand the forces of occlusion much better than a crown will, where all of that is being forced right at the margin.
Yeah.
And so the biobase refers to the medial dentin sealing, your resin coating, and if you blocked out any of your undercuts.
Yeah.
So that's the difference. So the biobase goes on the biorim. There's not an actual base or liner that is used in that traditional term, but so these kind of terminologies are very common among people that my dad has trained. He teaches with Dr. Matt Najad at Biomimetic Dentistry CE. So these are terms that we use just like people use just common day things. It's stuff I take for granted, but when I say that, it's like, what are you talking about?
Yeah. So the biobase is pretty much the tooth is ready to receive its restoration, be it direct
exactly.
or indirect. So everything's done, everything's ready to go. You're just going to put in the restoration now.
And so now we'll tie that into deep margin elevation or gingival margin elevation. So this was first introduced in 1998 by Davey Alleman and Robert Sprefico in PPAD. And they said, we don't necessarily have to always have the restoration sit on sound tooth structure. There are instances where it might be advantageous to elevate a margin so it becomes supragingival. Mm-hmm. And this is all theory in 98. And my father, he reads a lot. He read that paper and he was restoring some endodontically treated teeth, or he was getting ready to do endo. And on certain instances where you have a deep box and you don't want bleach to go down out of the chamber, what would be a smart idea to do? Maybe elevate that margin a little bit and then access, correct?
Yeah.
And so that's what he started doing. He started to elevate these margins and then access and do the root canal. And, this is in the early 2000s for my father. And at a time he's like, well, why am I going to go and grind this all the way down?
Yeah.
In theory, it's still bonded well. The endo's done. The hard part's done. Sometimes gingival margin elevation is the hardest part that you're doing.
Yeah.
And so he's like, well, I'm just going to start keeping it. And so when he started teaching in 2005, these techniques that eliminate crowns from a general dentist practice, he called it raising the box.
Yeah.
And, that's what he referred to it for quite a while. And then Pascal Magnier, who was the predecessor of Didier Dici, he wrote a very nice paper with Sprefico again, showing gingival margin elevation. And I think that's where, let me just pull it up really quick. I don't want to screw up the title. It's important to get the correct verbiage, I guess you would say.
This has been great. I've written down a lot of notes here. I'm just kind of looking at everything now. What percentage of dentists do you think actually think about this stuff?
I would say 0. I'm the only person who might be crazy enough to be thinking about this stuff. Well, maybe my dad.
Yeah, but do you think
Dr. Najad?
Yeah, the average.
I would say there's about 500 in the world that are thinking like this.
Wow.
In some regard, and they've either been trained by Pascal Magnier or my father or Didier Dici or Matt Najad.
Yeah,
and they're thinking about these things because they tie each technique with a piece of literature.
Yeah,
and I think with our conversation that we've had, I've stressed the importance of not just saying, "Oh, it works great in my hands."
Yeah, or I saw it on Instagram. So and so did it. Let me try it. Which I mean, it's unfortunate. I myself, I'll admit, I'm not a big paper reader. Because I just
but you need to connect with somebody who is, and if you connect with somebody who is and get trained by him, and it's I don't have to read all those dumb journals. I just have to make sure that guy's reading all those dumb journals.
That's the whole point of the podcast, man. I just I'm too lazy to learn myself, so I just seek out people who know what I want to learn, and I just talk to them, and I pick up notes, and hopefully it rubs off on me, and I get better as well. But I appreciate it. That's awesome. So the one thing that there's some debate back and forth. I talked to a few prosthodontists, and they're not a bit iffy on the whole deep margin elevation thing. Is so say if you're sitting an onlay on resin instead of tooth structure, based on the literature that you're reading and you're hearing, where is the failure occurring? Is it the same as you said with direct restorative, where if the composite fails, the base layer is still sound? So
exactly. So that's where I want it to fail. If it fails, I want the tooth to be still bonded.
Yeah.
So I've had one debond, and I learned a lot from it. So when I was in Korea, I did a nice onlay prep, did my immediate dent sealing, did my protocols very nicely, as best as I could. And, I get the onlay back, the patient's going to come back, and I'm like, okay, clinic, do we have any hydrofluoric acid? Do we have some silane? I want to, make sure I bond my Emax well. And they're like, no, we don't have any of that in the clinic. And I'm like, well, that's not great. So I call the lab. I'm like, hey, what, did you guys, pre-treat it? And they're like, oh, yeah, you're good. You're good. I was not good. So what ended up happening is, the manufacturer's directions with Emaxes, etch with 5% hydrofluoric acid for 20 seconds, correct? Now in this lab, they didn't have 5% hydrofluoric acid. So what did they use? They used their 9.5. And in their minds, it's like, well, what's the best thing to do? Let's
10 seconds.
10 seconds. Exactly.
Yeah.
And so they treated it that way. I silanated it, I bonded it. And, about, I would say it was 4 months. The guy was eating a now and later and, popped it off.
Yeah.
And it's like, no one likes to see their failures. I didn't like seeing my failure, but it was like, where was the mistake? And so what I ended up doing, I went on PubMed and I looked for literature to figure out what's the time frame that I need to etch Emax if I don't have 5%.
Yeah.
Because I went to the lab after that and I'm like, give me that 9.5 and let's figure this out.
Yeah.
I'm going to etch it myself. I'm not going to trust you guys. And what did the literature show? It needed to be etched similar to feldspathic porcelain. So 60 seconds was able to get, a bond of the Emax, at around 40 megapascals.
So 60, even with 5% hydrofluoric, you should be doing 60 seconds instead of the recommended.
No, so 5% still go by the manufacturer's directions.
Yeah.
You go 20 seconds.
Yeah.
Now with 9.5%.
It's so counterintuitive. It's weird.
It's very counterintuitive.
Yeah.
And I can see where the lab made the mistake, and I should have figured it out. But I became better because I went and looked up my mistake.
Yeah.
So, my grandfather was a new PhD physicist.
Yeah.
Worked on sonar.
Nice.
And my dad, he was a surf bum, and he was doing physics classes, and he would ask his dad about a physics question, and my grandpa, who died when I was just after I was born, he would always say, go look it up.
Yeah.
That's not what my dad wanted to hear. But, if you look it up yourself, if you kind of put in that effort, it sticks with you more.
Yeah.
And so some people will listen to this podcast. They'll get something out of it. They'll probably forget a lot of it. But if they invest in actually mastering these techniques, it'll stick with them.
Yeah.
That was the only paper that I paid for. Usually I go down to my dad's basement and say, hey, I'd like,
Yeah. So,
but anyways, I learned from my mistake in it.
That's the best way for sure.
But if you have 9.5, etch for 60 seconds.
That makes no sense.
And then silenate, blah, blah, blah.
We'll take your word for it based on the paper. So let's quickly touch on, I just want to see, I mean, you're right in there. You're practicing as a biomimetic dentist. Where do you see like the next 5 years, where it's going to be going? Is there going to be changes in like the trends of what is being taught in school even? What's the infiltration of this biomimetic style of dentistry going to be in the next 5 years?
Well, I think you have to go back to where it originated, and that is University of Geneva in Switzerland. So, a long time ago, they decided, hey, we're not even going to teach amalgam anymore.
Yeah.
So if we're not going to teach amalgam, they weren't the first one to stop teaching amalgam, but they were one of the first. And it's like, well, we got to get better at our adhesive protocols.
Yeah. I
mean, most people don't want a big chunk of silver in their mouth, or mercury if you really break it down.
Yeah.
About 50. But so they stopped teaching GV Black principles, and then eventually they got crazy enough to say, this adhesive dentistry is working well enough that maybe we don't have to cut teeth down for crowns. And so University of Geneva, now it's over a decade, they don't have any requirements for teeth to be cut down for crowns.
Yeah.
For traditional crowns. Now, what is University of Geneva produced? Some of the best dental researchers and clinicians in the world. So I've said Didier Dici a couple of times. Pascal Magnier is, right there. He's the one that basically proved that immediate dentin sealing quadruples your bond strength. Now, if you can quadruple your bond strength and get your indirect restorations to bond at a similar strength as the DMD of the tooth, we don't need retentive preps, correct?
Yeah.
I mean, the only reason to cut a tooth down for a crown, my friend said it best in dental school that I had corrupted a little bit. His name's Raul. He's in New Mexico.
Yeah.
Anyway, he said the only reason to cut a tooth down for a crown is retention. Now, if you can bond a tooth, do you need mechanical retention?
No, not in theory.
Not in theory.
Yeah.
Now, there's a lot of places you can screw up in your bonding.
Yeah. But I think even I've had this chat with a few people, and I think, okay, so if it fails, it fails. Like if a crown fails, it's usually pretty bad. Like the core breaks off with it, or it's leaking and there's decay underneath. But if your onlay falls off 4 months later, like it's not the end of the world. If your base is still there, you just clean it.
What do I do?
Bond it back on. Like
I etched it properly with hydrofluoric acid, 9.5 for 60 seconds.
Yeah.
Rinsed it off. Etched with phosphoric acid to remove some of this the crystals, the precipitate that formed. Rinse that off, silinated, air dried that well. Placed, bond, and then cemented with a heated composite protocol.
Yeah, and it's still there.
And it's there.
Yeah.
So when that failure happened, it was a secure bond. The tooth was still sealed. It wasn't the end of the world. When a crown fails, it's always bad.
Yeah.
It's always bad.
Yeah.
When I placed a clamp on a second molar recently and the crown came off, it's like, well, that's not good.
Yeah.
Fixing that tooth wasn't fun. People don't talk about that. It's like,
yeah.
I don't want a catastrophic failure. I want a failure that can be easily addressed, right then and there.
Yeah.
And that's what biomimetic dentistry provides. It provides a predictable way to fix structurally compromised teeth, or teeth that people would say that tooth definitely needs endo. And you're able to preserve the tooth vitality. You're able to preserve 50 to 70% more tooth structure than if you cut the tooth down for a crown.
Yeah.
You show a prep to a patient, like, do you want this prep or do you want that prep? Do you want more of your tooth or less of your tooth?
Yeah.
And they're always like, I think I want more of my tooth.
Yeah. I think that's the big thing. I think especially for a new grad, we're still getting comfortable with, case presenting to patients. Indirect is obviously more expensive than direct. So a lot of people who are like insurance driven or may not have the means. So a lot of new guys are maybe a little bit shy away from present that confidently as like, you need an onlay, you need this versus that. And here's why.
So here's the question. If you can do the class 2 as well as if you did an indirect, what should you charge?
You should charge the same fee as an indirect.
You should charge the same fee.
Yeah.
So that should be your goal. It shouldn't be like, well, how do I, present this? Now I'm in the military. Everybody gets whatever, I decided is right. They don't have to pay anything.
Yeah.
One guy gave me some Mountain Dew and some soda. That was great. That was the most.
You gotta be discouraging these behaviors, not.
No. It's great. The more cavities you have, the better golf.
Yeah.
But that's how you should be thinking. It's like, if I can stop the dental cycle, I should be getting paid for my time.
Yeah.
And if my time is $200 an hour, if it's $400 an hour, if it's $800 an hour, that's what it should be. I should be charging. And is that feasible for every practice? Of course not. But that's what you should be thinking.
That should be the ideal. That should be where you
because if you're making your adhesive restorations last 3 times longer than your competitor,
you should charge 3 times more.
You should charge 3 times more. And what's usually 3 times more? It's pretty close to an indirect restoration, right?
Yeah, that's fair.
And I mean, it's easy for me to say, oh, I've been out 3 years. I've only had 1 debond. I've had so many failures. Now, this literature has been, brewing for 25 plus years, and it's been taught and practiced, since the mid and early 2000s. And so we're getting 10 plus years where we're not having the same kind of failures that we were seeing with traditional dentistry, with recurrent decay, post-operative sensitivity, the same rate of endo, all of those negative outcomes that are associated with poorly bonded restorations have been dramatically reduced.
Yeah, no, I'm all for it. I think even just seeing the type of work and procedures that you guys are posting up, how much I like the intricacy of it. Like it's a lot of work it's a very technically sensitive procedure, but I can see the benefit of it. You're doing good work. It's going to last longer. So I'm a big fan. I think that's something that over the next, year or so, as I'm just trying to keep learning more and more things, I'm definitely going to invest a bit more time into biomimetic dentistry, because I think it's the bread and butter. Like, we're restoring teeth all day, every day. So you want to be good at it. You want it to last. You don't want it to fall apart. And I think, maybe even if you don't make as much money up front, because the guy down the street's just doing bulk fill flow, takes them 3 minutes to do. But you're isolating, you're putting a rubber dam on, you're incrementally like 1 millimeter thin. It's going to take 5 times as long. But eventually, if you build up the credential to be like, you know what, I'm going to charge you more, and this is why, because my work lasts longer, this and that, and back it up with educating the patient. I think that's the way to go. So thanks a lot for today. There's a lot. I think it's taking me back to like my dental school days. I'm like trying to remember, like, oh yeah, the side chain does this, and like a bifunctional monomer, like this and that, like HEMA. So it's a lot of words that I'm like, oh yeah, it rings a bell. So it's nice to kind of get a little review, and I'm sure people listening to this as well will learn a lot. And I think it's just scratching the surface, though. Definitely, I will be like diving into a bit more deeper, trying to learn more. So I'll definitely hit you up with some papers. If you don't mind putting together like a little list of 5 papers that you like absolutely recommend, then I'll put it in the show notes. So if someone's listening and they want to read more, they can get those titles. That'd be awesome. That'd be great for me as well.
I'd love to do that. I think it's really important that anybody that listens to this podcast, and this is speaking to them, it's like, oh, I feel guilty every time I cut a tooth down for a crown. It's, where do I go to get trained to learn these things? Now, this October, I'll be going out to Beverly Hills, and I'm going to, spend 4 days with Dr. Najad and my father to reinforce these concepts that I've hopefully communicated, clearly. I mean, I'm not going to get paid for anybody that signs up for it, but I see the value in it. So when I went last October to that course, I told my father and I told Matt, I'm like, that's the best course I've been to. I've been to a lot of CE I've read a lot of papers. And as far as, taking somebody from square one to being able to be comfortable to bringing this into their practice, I haven't found anybody
What's that
better.
course called?
So Biomimetic Dentistry CE.com is where you can find that information. And this is Matt Najad's teaching program where he focuses on posterior teeth. My father teaches alongside him with the literature review where they talk about a lot of these papers that, I've cited. And I always feel like if I want to be the best, I want to be surrounded by the best. Now, Matt Najad, he was Pascal Magnier's arguably best student, clinically, and then, he got trained by my father as well, got put in contact with him. And then he started mastering the literature. And it's like every case that he posts, it's like, I wish I could be as good as him. So if people are like, oh, I wish I could be as good as, Davey Alleman, which I doubt anybody thinks that way, because I don't even think I'm that good. But I'm the best that they got.
You'll be there soon.
Maybe.
You'll be there soon.
Kevin would say different. Kevin Lassiter. But I really appreciate you letting me be on. If people want, more information about that course, I'd be more than happy to share it. If they want, more, if they have questions about cases that I present, I encourage them to ask. I feel like I'm pretty responsive to, comment. I know you've asked some questions and you've gained a little bit out of it, and hopefully I haven't come across.
Not at all, man. Jerk. I think that was a great podcast. A lot of good information. There are I've written down a lot. Like there's so many things I'd never even thought about, let alone know the numbers about. So I think to start with what I'm going to take away from this, even just that 5-minute thing, I think if my restorations are 90% of their maximum bong strength, like if I can wait 5 minutes and get that, I can wait 5 minutes. It's like, it's not the end of the world.
Go do something. And when you think about that 5 minutes, you think about, I'm decoupling with time. And where did that come from? It came from David Alleman, not Davey Alleman. From David Alleman,
the senior,
the
undercover senior.
Yeah.
Awesome, man. So what I like to do is just end off on a quick rapid fire, just to lighten things up a little bit. So I'll ask the first question is, what's your favorite sports team? And you got an Indians hat on, so I don't know if that's going to be that or.
Yeah. I have an Indians hat. I'm an Oakland Athletics fan. They have a tendency to
a little money
trade away all their talent. Those were good times back in 2000 and what was it, 2006?
The Oakland A's. I like their hats. What's your favorite Instagram account to follow?
That's a good one. If I'm looking at anterior teeth, I really like. I would say Dr. Najad's. I mean, when he's paying $2,000 a unit just for the lab fee, they better look pretty nice. But as far as you're gonna have to edit this a little bit because I'm gonna have a lot of dead space.
Okay.
No. Well, let's come back to that one.
What is your favorite procedure?
A deep class 2 composite. I love doing that. I also like doing inlay onlays. Anything that prevents a crown. I hate doing endo. I'm not great with oral surgery. So if I can prevent, that's what I love to do. So give me a tooth that people are like, that tooth needs endo, and I'll put a little ice on it, and they get a response. I'm like,
nice.
We're gonna.
It's a good feeling when you save a tooth. I've done a few lately, and I'm like, they come in with like reversible symptoms. I'm like, we can try and save this, and they come back like a month later or 2 months later, and they're feeling good. You feel nice.
It's like
you feel good. Yeah,
you're their hero. Right?
If you can have one matrix system, it could be like the V3 rings, like traditional Toffelmeyer. What would be like one day, like if you can only use one for the rest of your career, what would you use?
So I'm gonna give 2 because sometimes I'm doing like gingival margin elevation, right?
You can only use one though. You gotta pick.
All right. If I'm gonna pick, I'm gonna say I'm gonna sacrifice my contact. I'm going to go with an automatrix. I love being able to just push that thing down to the, really deep, tighten it up. It doesn't have the weight of a Toffelmeyer retainer. So automatrix by Dentsply is what I've
never used one. I need to. We have one in my new place that I'm going to be starting up, so I'll start learning it a little bit. But I'm all like, if I'm doing a margin elevation of sorts, I'll use like a subgingival Toffelmeyer band, and then for the contact, I'll go back to like a sectional.
Yeah, you can switch over to like any sectional is going to work well. I'm not.
Perfect. And the final question for the rapid fire is, what's your morning routine?
I wake up at around 5:30.
Early.
Do some yoga.
Every day?
Yeah. So
that's pretty good.
Gotta maintain my flexibility. No, but I do yoga like 30 minutes.
Yeah.
Shower, and then I'm at clinic at 7.
You start pretty early.
We start early. I've never been much of a morning person, but the Army's kind of
drilled it into you a little bit.
Ruined me as far as being able to sleep in. So
awesome, man. Appreciate it.
Hey,
it was a great chat. We'll hopefully do another one. We'll follow up a little bit later on.
I think we'll probably have to. I didn't go too light. I might have given too much information.
I think it's good. If there's, I'm hoping people will reach out to you with some questions. It's always nice to get feedback after an episode. Some people hear back and some people listen and have some follow-up questions and they want to get.
Oh, for sure. Cool. It's been really cool just following your podcast and then kind of seeing some accounts that I wasn't aware of. So my favorite golf account to follow is Tony Finau.
Golf account? Tony.
Yeah, golf account. My favorite skateboarding account is Bucky Lassie.
Oh, yeah? He's still around?
He's still around. Yeah, he's not dead yet.
That's like Tony Hawk Pro Skater days. Bucky Lassie. Yeah.
And then as far as a dental account, I will say my own. No, just kidding. I don't know.
It's a good account. It's a lot of good.
No, I would say Dr. Najad. I think he's the best dentist in the United States. Big. I gotta try and if you can introduce us at some point, that'd be awesome if you could come on the podcast. I know he's a busy guy, but it'd be cool. He is a very busy guy. He's got a very high-end practice in Beverly Hills. He deals with, a clientele that's much different than the Army personnel. Mine's like, oh, that looks white and it doesn't hurt. That's great.
Yeah.
His is like, higher end, but I think if you want to really strive for that kind of excellence, you need to have that kind of attention to detail. Yeah. And then Biomimetic Study Club, run by Jeff Davies.
He's a great guy. I've had a chat with him as well. He's I think he's starting that course now too. I think he's working on something that just recently launched a bit. So.
Yeah. So he's kind of associated with with a lot of the movers and shakers, and I think he'll be a good person to connect with as far as someone who's got a pulse on where it's going. And then I got to give a shout out to Caleb Stott. His Instagram account is Clib Jong Il, and he's the one that told me, "Hey, Davey, you should do an Instagram account. You do really good dental work." And I told him, "I think it's just for food." And he's like, "No, you should do it." So anyway, without him, there would be no me, and there would be no podcast.
Yeah, no, that's good, man. I love your page, and I think there needs to be more people and that's something that I try and do, because obviously there's a lot, the Matt Najads of the world, the Apples of the world, they're going to be posting their stuff because it's just like, it's art. It's not even.
Yeah, it's totally art. So hopefully I'm like on the opposite side.
It's like dentistry. Like you're doing daily dentistry and you're posting about it at a high level. Yeah.
But the science is exactly where he's coming from.
I think that's so cool.
If I can inspire that, you can be inspired by the artistic side, and hopefully you get clientele that will pay that. But if you're in the Army and you're doing dentistry for you mainly, you can take a lot of joy in something being very functional.
Yeah, I think it's two-pronged, right? Like you need to have job satisfaction too, take pride in like what you're doing at work. That's important to keep you motivated, to keep you coming back day after day. Kind of like if you're just in there for like
dentistry's a grind.
If you're just
you gotta find those little victories. So like that case you posted that was a difficult anterior isolation case. Find and joy that your dam was good enough. I've had days where it's like that dam was good enough.
I'm pretty bad still. I mean, I'm just starting out. I'm just trying to take things a bit more seriously and kind of get better. But at the same token, I'm like a lazy clinician. I feel like a lot of times I'm just like, it's good enough. But I need to stop that.
If you're doing a slit dam and you got good matrixing, you're going to have adequate isolation. But the key is you got to know what the polymerization of your bonding materials are. So when people get really excited about dental dam pornography, realize that maybe you don't need the nth degree of isolation, but if you have a slit dam and, good isolation right when you're bonding the tooth, you can deal with a little bit of contamination later on and still have that seal to the tooth. So don't beat yourself up if your dam tears. Although sometimes that does ruin my day.
It is annoying though. You've gone through all the work.
It's super annoying.
And then, I think pre-wedging is like key for that too, because you don't want the dam interproximally to tear off. So that's annoying.
Especially when it's like, oh, that dam is so nice. And then all of a sudden you're like,
my pictures are ruined. It's all for the Instagram.
And then it's like, I'm taking pictures. It's like, well, do I replace the dam?
That's right. It comes to your threshold of what's good enough, I guess. But awesome, man. Appreciate it. Thanks a lot. I've kept you long enough here.
Much.
I'll really aim to get this out over the next few weeks. And this is a great chat, man. I know I think we started this chat like 4 months ago. I was like, oh, you should come on. And then I moved here and got a bit busy with things. So I'm happy it finally happened. And it was definitely a great chat.
Hey, it's been really nice because I feel like I've been able to get to know you a little bit better by just, following your podcast and listening to all of your guests. And, all of them bring something different and all of them bring something that's important to the table. And, I think we all learn from each other. And, I think I'm pretty smart, but there are people that are smarter than me. And, there are people that are definitely better overall dentists than me.
Yeah,
so
that's good, man. We're all trying to get better. We're trying to learn from each other, like you said. And that's the way to go. So thanks again.
So sorry for just talking your ear off. I can go forever.
It shows you're passionate. It's good when you're passionate about a subject, you can keep talking about it, right? So